Hello, Dr. Griffith, it's great to be with you. We've got a room full of people who want to hear essentially about where innovation in your space, and to remind the audience, you have the unique distinction of being the first person, as I understand it, I'm going to get the terminology wrong, xenotransplant, non-human hearts into humans, in this case a pig, and this gentleman that you did this for lived an extra 2 months. And I think right now, as we're discussing, what the critical points in science, in innovation, in health, and what's coming down the pike, you're sort of one of the pioneers in that. Where are we going?
Well, it's a good question. Most of us who toil, from the laboratory, taking in advances into the clinics, never really know where we're going until we test things. And our experience with the pig to human transplant really was declared a success in spite of the fact that our patient only lived 60 days. It was the first example of a genetically engineered organ, that could support life in a human. In spite of more than 10 years of work in non-human primates, which got us to a point of equipoise where we could propose an emergency use to the FDA. And the FDA treats these bioengineered, if you wish, genetically altered animal organs as drugs. So it's considered a drug. So if you want to use it like an experimental drug, say for COVID or anything else, you need to go through a drug portfolio of regulations. So we had an emergency use for this patient who was desperate and had no other opportunity for life. And what we learned was it worked. There are going to be a lot of things that proof of principle, we'll have to get back to, making better. But just like the Wright's airplane that only, flew 90 yards or something, for our first flight, I think, in spite of losing our patient, we learned a lot. And the patient was so sick, I think it was his illness more than anything else that did him in the end, not the organ. The organ never rejected, we believe.
So this patient, you were able to proceed because of a compassionate use authorization, because every other avenue this individual had was turned down or not possible for that individual. I guess my question in the FDA is the FDA friend or foe to you?
It's been very friendly to me personally, as an investigator who applied over the Christmas, New Year's holiday for permission to treat this patient. They worked tirelessly along with our team to get it right so that this patient had an opportunity. The regulatory hurdles are significant, and in many ways they should be. This is an important next step. We got to get it right, and a misstep would probably do the field a lot more harm than the initial sensationalization of the event. So I'm all in to the FDA, and I think if we do our job right, they have already demonstrated that they understand compassion and need, and the need for more organs. There are many thousand patients under kidney transplantation who need kidney transplantation on dialysis, something like 600,000, and so we've got to get that number way down, right? Going forward, 600,000 with severe end-stage kidney disease. And, there just aren't enough organs. And so the idea would be nobody thinks twice about, once they get a hip replacement approved, that they can go in and there'll be an artificial structural hip for them. Why not for hearts, lungs, livers, kidneys, and pancreases? It would be a huge healthcare burden alleviator.
I can tell, Doctor, that you are operating within the scaffolding and on the stage and in the parameters of, ethical and regulated treatments that you're trying to innovate. And I guess we have not coordinated on this question, so he may storm off stage. But what is the state of ethics in the world of bioengineering? I've interviewed, the people who created CRISPR before and others, and we saw in China misapplication there. We have a lot, when we talk about science, and we have a lot of focus on U.S. healthcare here, but there's a global medical scene out there. To what degree are you concerned that we've got some wobbliness in the ethics in bioengineering world?
Well, I am concerned. I've been a medical innovator for a long time, one of the first people to use an artificial heart, and that created biostorm as well, and I think that in the end, the biggest issue is patient consent, right? That the patient understands that this is an option and it's experiment. Once you get past that, the ethics of genetically engineering an animal organ, that's an issue that I think we can deal with fairly easily. Choosing the pig as a animal of choice, we hate to maybe take a life of any kind to save a human life, but if you're going to assume that someone's going to have to die for a heart to be replaced, human or animal, of the animal kingdom, pigs are those that maybe would be most easily understood. We would stay away from baboons, we'd stay away from chimpanzees, which would be easier to make a match for. But they're too close to us, and we wouldn't even imagine that. Animal rights advocates have been strong, and there have been a number of criticisms of what we did. And I understand that perspective, but the pig is easily raised, and they reproduce quickly and they grow fast. So if you're going to convert this into something useful from a commercial perspective, you have to have something like a pig in terms of a product.
In the health innovation space, it occurs to me that you're in the University of Maryland. One of the areas we've been talking about as part of that ecosystem has been our deficits in diversity and inclusion, the health outcomes. But I'm just interested, as you look around the room, about who the surgeons are, who the patients are, who the students are that are learning from you. What's the scene like, and is it different than it was 10 years ago?
Oh, it's a lot different. As a cardiothoracic surgeon, it was a field of mostly males, mostly white males, and very rarely were there women involved in that field. Consistent with the change in our entry of women into medical school, which now predominate over men, actually, in most medical schools, by a little bit, maybe a few percentage points more women. We have found that there doesn't seem to be a gender predilection for heart surgery per se, and some of our best candidates for residency and our best residents now are women. Diversity is a problem in medicine for lots of reasons, and I think that our medical schools are working hard to adjust for that purposes, like all great institutions of education.
Right.
It's a crisis, and we need to work for it. I'm proud of the progress that's being made, and our graduates who are going into all fields of medicine are diverse, more so than ever, and the data would suggest we're getting there.
Dr. Griffith, let me finish with a fun question. Some years ago, I think it was about 15 years ago, I had a cool dinner in the Bay Area in San Francisco with some of the founders of Google and Oracle, and our chairman at New America was there, Eric Schmidt, and the topic of the dinner was how to end death, that we would one day have the technical and scientific and methodological capacity to efficiently end death. We had a couple of DC types in the room who then said, it's going to be terrible for entitlements. But I guess my question to you, as you look at the frontier of science that you're at, is that a ridiculous presumption? Are we getting to a point where we will be able to at least extend life so significantly that it creates a very fundamental shift in the social contract in this country and around the world?
Well, I think we're going to get older. Whether we're going to perpetuate life, I think we'll extend life for sure. And I think in the lifetime of my grandchildren, we would see a life expectation, go up by 10, 15%, which is huge. And I think there are lots of reasons for that. If we start thinking a little bit beyond that, you have to define life. And
Right.
Is life just your brain? And, the body may wear out, and maybe you'll be transferring brain, if you wish, onto a younger pedestal, which could be bioengineered. So, yeah, let's go Star Trek and think big. But we've got a lot of problems to worry about, and I don't know that extending life should be the proof of principle
Right.
of our great medical advances. We got to take care of the good people we have, and I see a lot of people dying prematurely from all sorts of reasons.
Right.
And it starts with accident prevention, addiction, and then natural processes of cancer and heart failure.
Final. Do you have other patients lined up or out there that could benefit from what you achieved with this zero patient, this first patient that you had with the pig heart?
Great question. Short answer, yes. But we're not ready to pull that trigger and ask for one until we have exhausted all that we could learn from our first patient, Dave Bennett. We're just about there. So hopefully we'll gather up our summary of that and then find a patient in need. People have written to us, of course, and the average patient with cancer can't be transplanted. So we have an avenue for patients that have no option in that regard. So I think we'll find better candidates. Dave was really sick, and I think one thing we've learned is having been successful for 60 days, the principle is there, so our next patient doesn't have to be on that real.
Well, ladies and gentlemen, this is a real biomedical pioneer, Dr. Bartley Griffith, professor of surgery at the University of Maryland School of Medicine. Really appreciate it. This was a lot more fun than I thought it was going to be, so thank you.
Okay. Thank you. Bye.